welcome to Monday afternoon at Global Conference. I hope everyone's enjoying themselves so far. The good news is the crowds are light. There's, I'm teasing. So I hope though you've had a good day so far. I know I have. It's been an interesting time. This is going to be a great discussion with three good friends about a topic that could not be more important to everyone in this room: our families, our society, and frankly, society is well beyond our own. Which is we call it prescription for health, but it's really about the critical importance of improving health in aging populations and the implications for us if we don't, and the opportunities for us if we do. So with us we have our good friend Pincus, or as we all call him, Hasi Cohen, who's the Dean of the Davis School of Gerontology, University of Southern California; Frida Lewis Hall, who many of you know, the Chief Medical Officer of Pfizer; and Yves Joannette, who is a professor at University of Montreal, and also who heads for the Americans in the room, the Canadian equivalent of the NIA. So Yves is the guy who kind of is the capital allocator and principal strategist on aging and health north of us, where of course they think these things through more carefully than we do. So Yves, you'll talk about that in a moment. So I want to principally focus on opportunities, on the progress we're making and the potential for the future. This is something that again impacts every one of our businesses, every one of our lives, and certainly our families. But I want to spend just a little bit of time talking about where we are, because I certainly don't want to sugarcoat the facts. So Hasi, let's start with you. We know we have a series of challenges in brain health and diabetes, and although just a little bit of kind of the landscape for us. Where are we today?
If I can have slide 18 on the screen, I'll start by first of all thanking Paul Irving for focusing the conversation on this incredibly important area. And it's not that it's all bad right now. We've made incredible advances in particularly in increasing lifespan over the last century. What we have not done as well is improving what we call health span. And the lifespan minus health span is what we sometimes call the disability span. And older Americans, a fair number of them, now live in a state of disability, chronic disease, and in fact women who do live longer than men by about 5 years spend at least half their time spending more time with a disability than men. So I think that the big challenge is not necessarily to make people live even longer, but rather to increase health span, to delay or prevent the onset of chronic diseases of aging, particularly dementia. And of course, the incidence of Alzheimer's is a critical issue here. The interesting thing is that the number of people with Alzheimer's at any particular age has actually gone down over the last few decades. But because so many of us are living longer, the number of people with Alzheimer's disease is increasing at an alarming rate. And there's a lot we can do about these things.
Okay. Frida, I know you think a lot about this in the context of one of the largest companies in the world focused on cures, but what do you see in this kind of landscape of disease that we confront today?
Yeah, so there are two things that I'm really particularly excited about and then particularly concerned about. First of all, excited. If you really look at the differences in lifespan and some in health span, much of that can be attributed to biomedical research and advances in science. If you just look at 2000 to 2009-ish, about 73% of the gain during that period can really be attributed to direct life sciences biomedical innovation. And that's all wonderful. And I'm excited about what is about to come. I mean, we're in a platinum age of science now. I suspect that what we see in the next decade will be stunning, and much of it unanticipated and frankly unbelievable. So now the downside. if you think about chronic illnesses, non-communicable diseases, which are on the rise, which often account for that disability span that Hassie mentioned earlier, two things. First of all, many of those are preventable through lifestyle changes and modification. And the second thing is, many of those are modifiable with tools that we already have in hand. So, an example, hypertension in the United States, 67 million people with hypertension. 36 million of them are not controlled to goal. 14 million of them don't even know they have hypertension. So we arguably have everything we need in terms of knowledge about health, health practices. We have tools in the form of medications and other things, and still.
And this is actually a relatively inexpensive solution, right? I remember Tom Frieden, head of the CDC, saying this is the one thing, if he could just take on one thing, the easiest thing he said would be hypertension.
And he has with the Million Hearts program, and that's beginning to roll out. But I think it's just such a poignant example of how, in many cases, we have an opportunity to make change, either through individuals or through a collective. And my biggest fear is that we won't leverage that.
And if I could just add to that, we can certainly diagnose more people with silent hypertension and treat them, but we can do even better by getting people to exercise.
Exactly.
And we can prevent tens of millions of cases of hypertension. And of course, we can throw billions of dollars into research on the mechanisms of hypertension and develop new drugs. God knows I've done that most of my career. But just getting people out there can save this country trillions of dollars.
So I want to come back to both of you on kind of this huge question about what are the impediments to success and frankly things that we know that work. But Eve, observation, you've spent most of your life in scholarship focused on brain health, but obviously you have a much larger portfolio in Canada. What are you experiencing?
So meanwhile, back north of the 45th parallel, things are more or less the same, in fact. And we've seen an increase of life expectancy. And it's time now, research has been contributing a lot in increasing this life expectancy, adding years to life. We now have to add life to these years and to make the reverse kind of approach. And I think we have to make sure that we do not only target healthy aging. In fact, the World Health Organization is talking about active and meaningful aging. And I think that's a better expression. Now, the impact is and the source is not only on the body and the biology, it's also on the society. Just imagine the US, Canada, we added 20 years to our life expectancy over the last 50, 60 years. It took about 120 years in Europe. So they had time to adjust to these changes and change the structure of the societies. In some countries, like I was in Chile last year, can you imagine their life expectancy increased by 20 years over the last 19 years? So just imagine the impact on the society, the shift they have to make. So it's not only about the body; it's also about the society and how aging is perceived in the society and the stigma of aging. I think we'll talk about it today as well.
So let's turn for a second to the prevention discussion, which to me is just frankly a quandary. So we spend about 3.5% in the United States of our federal health budget on prevention and wellness, the thing that we know that works. And Frida was talking as we were prepping for the meeting. We were talking about the consequences, the huge challenges of obesity, and your comment was kind of easier said than done in effect. So why is that? I mean, what are our barriers to achieving something on a condition that we know has such unbelievably important health impact? We all know the right thing to do, but we just don't do it.
Well, seemingly simple, frighteningly complex, is the end of the day. And, we do know some, but a lot of it is, a part of the conversation earlier is, we've done this collectively, and we've done it informationally. Let me give you this information and then expect you to do it. And frankly, many times you don't. Some of us do. But what we haven't done, I think, is to provide motivation and introspection so that people understand, and then incentives, so that people really understand how to get it done. I mean, I'll do a true confessions. It's a small group, and I had a moment.
We're off the record.
We're off
here.
the record.
Yeah.
So I had a moment, I guess, about a month ago with this wildly elevated high blood pressure, which was very different for me. And you know, so I rushed to a cardiologist, and you know, I'm absolutely panicked. And my mother died of a stroke just shy of her 52nd birthday, and my grandmother had, you know, cardiovascular disease and on and on. So I'm like, oh my gosh, it's here. So I rushed to the cardiologist, and she's doing my history, and she says, smoking? I proudly said, no, never. She said, exercise? I said, no, never. She said, that is not funny. And then when we finally got to the end, I mean, you know, pages and pages of this history, and she finally, I finally said, you know, you never asked about my diet and nutrition. She said, some things are just obvious. So why am I telling you that? Because I have read as much as anyone else. I have seen as much as anyone else. I have advised as much as anyone else. But somehow converting to what the personal dynamics are, and you know, what would actually move me from this, you know, weight of knowledge and information to actual action is baffling. And so if I can't do it for me, and you know, you can't do it for you, how are we going to do it for 300 million people?
So I mean,
or you know, billions of people around the world. How are we going to do that?
If you don't know the answer to this at Pfizer, I don't know who in the world would. So you figured out this pill to mitigate the effects of certain cardiovascular conditions. You also did something for many of the men in the audience who will not admit it. What are you doing on weight?
Well, there's Hassie's looking, and I'm sure that, I mean, there's so much that's going on. Both in preventive to understand the mechanisms, because all weight issues, all obesity is not created equally, and personalized, not just personalized interfaces and insights, I think will reign the day, but also more personal information on what really works for you and what really works for you. And I think we remain not nearly where we need to be. One of the things I think is interesting, slide 44, is this notion of this idea that we are truly multifaceted, and the more information that we know about ourselves, you know, kind of layer by layer, the more we will, as a healthcare system, be able to deliver truly personalized care. So if you think about it, my genomics, my proteomics, my microbiomics, my exomics, like my environment around me, all of these things uniquely impact me. And what we haven't cracked the code on is what Google cracked the code on in terms of using a GPS system, layering these things one on the other, and then using a point in time, for us it would be the patient, to kind of triangulate around what all of those different elements mean for them, and then truly personalize an intervention. You know, this is a part of what will happen with the patient-centered information commons as a part of the precision medicine platform that was recently announced. But I think it's such an elegant model for what ultimately we have to get to in terms of individualized aging.
Yep.
And so if I'm understanding from a lay perspective, the much more detailed individualized information will also more likely incent the right kind of behavior. And in effect, it takes away plausible deniability, right? You know, cheeseburgers are bad for just about everyone, maybe not for me.
No, honey,
Hassie,
cheeseburgers are bad for you too. I mean, once that happens, then you know you're in, right?
So just to plug in for Father's Office, the best cheeseburgers in town, which I have twice a year because I otherwise don't eat meat. So I think that personalized medicine has completely revolutionized healthcare, or what really we should call sick care. The challenge is, you know, for healthy aging is to take that to the pre-morbid state, and it's what I term personalized aging. We're taking the power of genomics and epigenomics and turning it into a motivational opportunity. So we've already started doing this and if I can have slide 23, in the personalized aging initiative we have at USC, where we use the $99 platform of 23andMe to identify several dozen SNPs or genetic susceptibility markers that help us identify who might get what. And we have markers for high risk for Alzheimer's disease that will take patients to a completely different set of prevention approaches, markers for diabetic risk, that if you add that with biomarkers and weight issues, you can tailor a program for diabetes prevention, markers for cancer risk, which again will give you a different type of approach to prevent whatever it is that you might get. And you said, why isn't prevention working? I think there's two things. Number one, if you're just a person who's currently healthy and you get all this advice about what you should do, it doesn't feel personal. I mean, it's not really going to happen to me, or if it's going to happen to me, it's going to be so long. You know, why should I not have that hamburger today? But if you get this genomic and epigenomic information telling you that you're very likely to get one specific thing, suddenly it becomes real and personal, and you can address it. And if we're going to do some sharing, I can tell you I did this panel, and I was expecting to find all kind of scary things. I learned something that I didn't even suspect I was going to have, which I have high risk for deep vein thrombosis. So I changed my exercise plan to include at least an hour a day of walking. I take an aspirin every day, and I don't fly coach. It's all true. And you should know, my father...
That's okay, neither does anybody else in this crowd.
My father died at age 70. And at the time that he died, that was the mean for the male population, so it's not terrible. But his sister, who was a couple of years older than him, lived to be 102. And you think, what made her do that? She has the same genetic background, and being a female only gave her an extra 5 years. Well, she was vegan. She was a dancer. She danced 2 hours a day till she was 95. So it kind of makes you think there's personalized elements that can make anybody change their lifestyle. And I know I have.
So I want to get back to Eve and dementia. So in addition to the massive costs and risks and the tragedy and the caregiving challenges and all the rest, one of the things that I think we find is really an interesting phenomena is, even for those not at risk or for those not experiencing it, anxiety about dementia is a huge problem for aging populations. So do you have any advice from us on
well, I
what
won't
we're
invite
facing?
you to stop aging, because it's not a good alternative. But certainly any adults, and if I would make a poll here and raise your hands, I think having dementia, Alzheimer's disease, cognitive impairment is probably what we fear the most when we're midlife adults, as you are, and when we're advanced in age. And so, and this is real true. We had, in order to prepare our strategic plan, and I like the first page of our strategic plan, of course, it's on slide 33, in order to plan in which area we would invest in research. We did a tour in Canada. We called it the Speaking of Aging tour, kind of a rock star kind of tour. And we went in all the cities. And this was one of the most important things that was mentioned by lay people, by community associations, by even clinicians themselves, researchers working on diabetes. When they were asked, they were saying, I fear Alzheimer. And there we're learning, we're starting to learn exactly how it works. Slide 37, for instance, and I'm showing this slide. Why? Because education is very important. I strongly support what Ossie was saying in you, because of course we have to empower ourselves, but to be empowered is not only to be told, eat broccoli or do bicycle. We have to understand what's going on. If I explain to you in 1 minute what is the course in your life of neurodegenerative diseases? You see these curves. Look at the red curve. This is like the lifespan going for someone who has dementia. This is Alzheimer, but most neurodegenerative diseases is the same. And what happens is that when someone is diagnosed with dementia, it's at the right part of the graph, the damage in the brain has been there for many, many years. And if you go backward, you have 15, 20, 25 years before any clinical sign, the presence in the brain of those damage that are starting in some people. Not all, it's a disease. It doesn't come with aging. So we have to understand this, and maybe one day we'll be able to offer very early indicators of whether or not someone is on the trajectory towards dementia. Now, some people would say, and some ethicists are saying, no, 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 don't tell people we don't have the drug. Well, we don't have the drug, but we might have some ways in terms of lifestyle, in terms of enhancing the cognitive reserve, and we can talk of that later on. We can either push back and delay this disease. So you could choose. It's individual, as Ossie was saying. It's a personalized decision. Do you or don't you want to know? And maybe one day you'll want to know. So this is an example. If you're informed, if you know how the process is working, then you're going to be better having your hands on the handles of your life.
Well, and if nothing else, you're able to plan. So, so I want to change the conversation for just a minute. If I can have, I'm just going to throw up one or two slides very quickly. Slide 1, please.
That's an easy one.
So just some very fast context on aging that I suspect most people in the audience know, but if for some reason you don't know. Global life expectancy obviously continuing to increase very, very radically. Let's go to slide 3 for a second. Fastest growing population, 80 plus. You'll see on slide 4 some global stats, and what's really interesting is aging is very much not just a North American phenomenon. In fact, we're actually aging on a relative basis slower than some of the rest of the world. We know that Japan is the oldest developed country in the world. Europe aging much more rapidly than the United States, and as Yves said, in Latin America, Brazil aging very, very rapidly, Chile and other countries. So you know, age is here. Age is a fact for us, and the question is we have this wonderful longevity dividend. We have this opportunity to do exciting things with this new period of life, and how can health help us realize that? Because ultimately, I suspect health is the principal impediment to enjoying the benefits of this longer life. We know, for example, that when we see statistics about projections for increasing longevity, one of the key mitigating factors is again obesity. People say, will obesity actually repress the life extension that we see? So talk a little bit about, with this in mind, we know our parents' generation has lived longer than we expected them to live. Our generation may live longer. I suspect we're all in the same gap, and our children face the exciting possibility of much longer lives. As I mentioned this morning in a panel, Art Levinson at Calico, funded by Google, who's the chairman of the board of Apple Computer, founder, former chairman and CEO of Genentech, Craig Venter, who's going to be here on Wednesday. A lot of really important people in science, very focused on longevity science and believing, and we can all discount the numbers, but believing that lives that are significantly longer are possible. Frida, this goes to what some of what you were suggesting. So is it 100 or 110 or 120? I don't know, but for those of us with millennial kids, they really have to be thinking about the consequences of not only prevention and wellness, public health, but things like, again, Alzheimer's, where, 50% roughly of those 85 plus
Yeah.
suffer days. So you can imagine this really scary relationship of potentially much, much longer lives and this continuing very high risk of tragic disease relatively early. So as you look forward, what do you see as the exciting possibilities? And Frida, you were talking earlier about things that you saw that would kind of blow your mind in medicine, and I know Hasi, you think a lot about this too. Why don't you start and let's talk about how we're going to solve these things for the next generation.
Well, I'm actually, if I put aside cracking the code for helping people do the things that are healthy for them, so kind of the prevention platform. If I put that aside and just think about what I think might be possible in the future from a biomedical standpoint, I'm really thrilled about the idea of vaccines. And not just vaccines for communicable diseases, but for non-communicable diseases. So imagine a vaccination, against some cancers, and actually we already see that. Imagine vaccinations against obesity once we are able to really understand the subgroups. And evolve our science. So I think, I've said about 3 years ago, I watched a man jump out of a Mylar balloon from 24 miles above the earth and land on his feet. I figure if he can do that, we can do pretty much anything in terms of the biomedical space, and we're really delivering those things day on day. So I envision in the not distant future kind of the Star Trek notion of that's Hasi's already started, right? So where I really understand all the things that could potentially happen to you, and I begin to vaccinate you against those things that you're at risk for, because I have such exquisite understanding about how those things will evolve.
Eve?
I think, well, we're trying to fund the knowledge of the future that we will benefit from in order to answer your question. And in my crystal ball, and in the checks we're sending to this group, we're funding the Canadian longitudinal study on aging, because where we are standing now is that we have all these bits and pieces of information here and there, and we know, exercise, we know this and there, and the genome and the epigenome, but we lack the overall synergy between all this. And to approach the trajectory of active and healthy aging in understanding all the determinants, they're very complex, which will allow the stratification of the population in order to really know what's good for one and the other in a cohort which is followed longitudinally. So you have the same people that you follow for 20 years. Well, this is one of the studies that we're funding currently, and I'm very happy to share with you that this month, April, is the landmark, because they have completed their first turn of recruitment, 50,000 men and women that will be followed for 20 years. Age of entry between 45 and 65. So you'll have the entrance, from 45 to 65. You'll have 60 to 80. You'll have 85 to hopefully 105. And so we will have all these information. The only thing missing, and we're thinking about adding this, is the microbiota. All the microbes we have, we have about 10,000 times more genetic variety in our body, in our microbiome, than in ourself. And this is having an impact on aging as well.
I see.
So, I think everybody on this panel, and quite a few people in the audience, all have a vision of how they're going to take a couple of $1 billion or $500 billion in my case, and create the future of healthier people with designer drugs. But most of the people who come to this conference are asking themselves, how much is this going to cost us? And if I could have slide 32, and I think that the most expensive thing society deals with when it comes to aging is chronic care of dementia. And right now, it's $250 billion a year, and that doesn't count medications. You know why, Frida? Because you haven't made any that work. I know you're working on it. But it's all care for patients with Alzheimer's. And if we just continue the way we are doing, just with people living longer, the cost is going to approach $1 trillion a year just to change people's diapers. If we could get people to diet and exercise and learn a second language and take ballroom dancing, whatever it is, and delay Alzheimer's disease on average by 5 years, we can save this country $500 billion a year, which I only want 10% to go to my laboratory. You know, so this is a proposition that is worth the public investment, is worth the kind of lobbying that we do for more health care. We need lobbying for more prevention.
Well, so if it's that easy, and it sounds that easy, I know it isn't an application. So why aren't people talking about it? Why isn't it happening? Look at the budget numbers. Look at the public conversation. I don't see it.
You're the policy person. Explain it to me, because the numbers speak for themselves.
I'm at a loss. I don't understand why something that we know that works wouldn't be the subject of greater public investment. But I think it may be some kind of disconnect between understanding the impacts of health on the broader economy, on social fabric, on civil society, et cetera. I think in some ways, I'm the only non-doc on the stage. I think in some ways it's because the health ecosystem is kind of segregated from the rest of society. In some ways, self-segregated. And I think one of the questions is how do you integrate health as a discussion, conversation? Our friend Risa Mori at the Robert Wood Johnson Foundation talks about changing the culture of health, embedding health conversations in discussions about how to make business more competitive, et cetera. But I'd ask all of you. I mean, you know, Frida, you're constantly on the Hill. You're talking to leaders in business. You're talking to leaders in policy. You're flying around the world making speeches.
Frida, you were just constantly talking.
Constantly talking. How come people don't get this and don't get thinner, don't work out more, and don't focus on this more with their employees and their public?
So I think we should do it in two different questions. Okay. One is, why don't individuals do it? And if I knew the answer to that, I would answer it for myself. My Fitbit thinks I'm dead most days. The slide that you just had up is a great one, though. So if you take it from the individual, where we haven't cracked the code on producing incentives and opportunities and insights and all the things that would lead you to the behaviors that you need, and you to the ones that you need, and me to the ones that I need. If we took that off the table for a second and asked ourselves, why collectively are we having a hard time talking about this and actioning it? I think it's what you said, Paul, which is right now, first of all, we don't have a healthcare system, we have a sick care system. Right. In fact, I have a friend who says to me, you're always talking about the healthcare system, and I don't know why, because we ain't healthy, nobody cares, and it ain't no system. So, you know, I tell her, I don't agree with the middle part, because I think a lot of people care, but the other two, unassailable. I mean, just true. So we're not healthy, and it's not really a system. So I think one of the things that we have an opportunity to do is exactly what you said, is kind of collapse ourselves together to make this a meta collaboration across all of the sectors. This is really around education. It's around, you know, parks and recreation. If we just use the U.S., it's around the economics for families. It's all of that together that creates a constellation of opportunities to adopt a healthy culture as a community and healthy practices as individuals. So I think until we find a way to move all of those things, at least in proximity to each other, so that we're having the conversation, we're not really going to be able to affect the change that we need. And I think the idea of saying, why don't we do more prevention, is just too big. I think we need to be specific. We need these three things to happen, and here are some programs that have demonstrated that they work, and let's talk about those things. I think that is doable.
Those of us are, remember, the President's Council on Physical Fitness, right?
I think those are doable.
Yep. So I've been interacting in the last year with individuals from the life insurance industry as opposed to the health insurance industry. One of the areas I think that's being, in a very innovative way, changing the practice in that industry is the concept of using incentives in the form of reduced life insurance policy cost to get people to get their act together, exercise,
stay
and,
healthy,
you know,
or
to
drop
the
your
point that
premiums.
your Fitbit sends the information to your life insurance, and if you reached your 20,000 step that week, then your discount comes in on your life insurance premium. And the same thing you can do with many other preventive elements. You can use incentives. You can use the guilt factor, as I said. I want to program my Fitbit to tell me, for 3 days, you haven't walked. Some people got it.
With his mother's voice.
And some people, you know, respond to competitive challenges. You know, your neighbor did 20,000 steps and you already did 18. You're almost there to beat him. And whatever works for people, there's a way to design approaches.
How much of this is as a result of, and Eve, I'll pose this to you because you have a different payment system. How much is this a result of personal responsibility challenges, disconnection between patients, not only patients and their caregivers? We used to have somebody mentioned Marcus Welby, right? We used to have the doctor come to our house, and the doctor was part of our family, but also the question of payment. You used to go to the doctor's office, you pulled out your checkbook, you wrote a check. These days, you have no idea what your care costs, and in fact, your care costs seem so insane, frankly, insanely large oftentimes, and frankly not credible. They're negotiated, they're changed. You get 6 different statements. If you're that disconnected from not only the provision of care, but the cost of care, how can you partner in that relationship?
Well, you're referring to the fact that Canada has a public health system. I think you heard about it last year when there was some discussions.
We did.
Some limitations of the system, but it's generally not bad. And in fact, maybe you don't know, we don't have a public health system. We have 13 public health systems because each province has a health system. They're all universal, public, no private, but still. And how to, bring this system. First of all, the public health system has a non-trivial component of public health and prevention. So you have to invest in prevention, because if not, as Ossie showed, you'll pay the $500 billion more in dementia if you don't pay a little bit of money upstream in the process. Now, this is not sufficient, and money is not sufficient. It's also knowledge. Health service provider, health policy makers, they tend to take decisions on the basis of anecdotes more than facts. And so us, funders, and the research side, we have to do more than simply provide the new knowledge and support the researchers. We also have to bring this knowledge to those users. And for instance, in Canada, we have this program called Best Brain Exchange. So it's offered to any health service provider of any province or any policymakers if they have to make a decision and if they're worried about, let's say, preventing dementia. Well, they call CIHR, the Canadian Institute of Health Research, and they will have 2 days, about 4 or 5 experts from Canada around the world. It's going to be behind closed doors. It's not a public meeting, and it's going to feed them into their decision. So we have to do things more and more in line with the health policymakers.
I also want to make sure that we think for a minute about the social determinants of health. You know, not everybody has a Fitbit. Not everybody has a grocery store that has healthy food in it. If you go outside of the U.S., for example, not everybody has clean water. Not everybody has, I mean, we could make a list of things that people just do not have. I don't have a safe park. I don't have a safe street to walk on. So I can't walk for 2 hours a day because I'm afraid for my health. And I can't let my children do that either. And my kids are hungry. I mean, we could just do the whole list. And many of these people, we end up in unhealthy lifestyles, not because we've heard all the information and have chosen to be in that, but that, you know, kind of our lives have put us on a path that has led us to unhealthy behavior, either because we didn't know it or we knew it, but we couldn't prevent it. And so many of the things that we have an opportunity to do, I think, collectively, and Risa Lavise-Moray and the Robert Wood Johnson Foundation has tapped into this a little bit. What can we do to make streets safer, to provide safe exercise zones, to provide opportunities for children and adults to do that, the things that they know will be healthy? How do we assess the health of the food that's available in a community? And is there a way to provide incentives through couponing and other things that if you go to the grocery store and are going to buy something healthy for your family, that that coupon brings it to the same price that it would be if you made an unhealthy choice or a better price? So I think that there are some opportunities for us to do some very different things to provide opportunities for people to make choices that we can inform them of. And I want to make sure that we don't lose that in the conversation.
Absolutely.
Because that's what requires, I'm looking at you because I know that there are a lot of opportunities in schools of public health that are looking at health disparities and gaps and how we can shape-shift what happens for people every day. And I believe that there's a tipping point. There's a point at which we've made this available to the point where people are not thinking about whether or not this is an unhealthy or a healthy choice. They're just naturally bent to the healthy choices. It becomes their lifestyle. And I think we've not, frankly, done collectively a very good job of either understanding what those barriers are or providing ways to close those gaps.
But by the way, one of the things that we're going to do today, because our colleague Linda Freed, who was supposed to be on the panel with us, unfortunately couldn't be with us. So guess who the fourth panelist is here? It's you. It's you. So we're going to come to you in a second for questions. So be thinking about them. And by the way, I would challenge, following on Frida's point, I would challenge my friends in the audience who are maybe not from the health world, but who are economists and finance types, to be thinking about the the fully loaded benefit of addressing some of the things, Frida, you're talking about in the social frameworks: safe streets, safe schools, healthy food choices, addressing food deserts and the like. We tend just to focus, and again, I think the health care ecosystem bears some responsibility for this. We need more health economists in schools of public health and in medical schools to really understand not just the health costs or health benefits, but all of the costs and particularly all of the benefits associated with better behaviors. And
even I had a slide, right? We looked down at our slides. We were like, "Is that your slide?" No, I think that's my slide.
Yeah.
Can we do 42? Is that okay?
Well, 41 is better.
Okay.
No, 42. No, 42.
So 42.
That's 41.
So that's 41. It doesn't matter. They're really the same slide. So this is really, I think, a great depiction that shows that a lot of benefit is gained by simply keeping people out of the disability zone for even a brief period of time. I've come to call it the cystic fibrosis foundation mechanism, right? So the question that they asked wasn't, how do you cure CF? They asked a simpler question, not a simpler question, but one that felt simpler at the time, which is, how can you change the lifespan, the life expectancy of a child diagnosed with CF from 25 years to 50 years? That seemed like a different kind of solution to find. So I think one of the solutions that we have an opportunity to look for is, what can we do to keep different cohorts of patients out of the disability zone? For Alzheimer's, a year wins you, a $500 billion or $250 billion, and doing that with diabetes wins you not just health for the individuals and for the families and the communities, but also a lot of money. So one of the things we can start to problem solve around is how you kind of lift that orange line up to begin to meet the green one. And I think that is the kind of thing that derives the economic benefit, may cost less, may seem more plausible, and to provide near-term results for us. So I think it's exciting. And then you had some points on that one too.
Eve, you had a point. Hasi, you had a point. Now I'm going to go out to the audience.
I just want to mention another point which is related to this, and the importance of the top-down as well. And just to mention that even politicians can be useful in this. And maybe if you put slide 38, this is David Cameron. well, he's under election now, but he was Prime Minister of UK. And in December 2013, he took advantage that being heading the G8 group in order to make a call for action, because all these things we've been talking about, they're too grand to be addressed only by one sector. So we need industry and public research together. We need countries working together. And it created an immense impulse. I mean, just as an example, three months after this, my Minister of Health was there, signed the call for action, and we had our Minister of Finance adding a $35 million investment in the Canadian Consortium on Neurodegeneration and Aging. And just recently, next slide, it culminated about a month ago in Geneva, where 80 countries now have signed the call for action. 17 countries from all the Americas, including the US. And so this is a way where politicians can be useful and impulse, inject money. There was in the US, there is in other countries, and really make a difference, not only in terms of research, but also in terms of creating a society which is better for all those, like the Dementia France program that we can talk about.
So you know, I agree. I think the key is a public-private partnership that brings together universities and government, but the one element that hasn't been spoken about is how employers can really make a difference. Absolutely. By mandating physical activity, controlling what's in the cafeteria, you know, limiting the trucks outside the employment place to only fresh foods or whatever. And not only is this going to work for people 20 years later, you can actually reduce the cost of healthcare for a large employer by insisting that people have a healthy lifestyle.
So this is a perfect segue. As Hasse was talking, so we're gonna go to. I saw our friend Steve Bird in the back, as former chairman and CEO of Safeway, chomping at the bit, ready to react to this comment. So Steve, if we can get the mic over. And
I was thinking about Safeway.
Let's all by the way try to keep our comments short to give everyone a chance.
I'll try to be,
Steve.
I'll try to be brief, but I've been sitting here wanting to answer your question about how do we change this. I would just ask you to think about the automobile insurance industry for a moment, and I want you to think about two things. If everybody in this room, let's forget this room, if everybody in the Los Angeles basin paid the same amount for automobile insurance, regardless of DUIs, regardless of speeding tickets, regardless of accidents, and then when our cars needed to be repaired, we went to a repair shop, and it didn't matter if they charged $1,000 or $15,000, they got it repaired and fixed, and somebody paid 80% of that. That's the way healthcare works today. And it would be chaos, and automobile insurance rates would be through the roof. So I would suggest, I mean, it's very complicated. That's why we never solve it in one of these sessions, but it boils down largely, I think, to personal accountability and transparency on cost and quality. And you have to make provisions for people that don't have safe neighborhoods. You have to make provisions for parts of the world where there's not clean water. We have to make provisions for all of that. But you can apply market-like principles, as we did at Safeway, and had dramatic improvements. In obesity alone, we reduced the rate of obesity in the workforce by 25% in about 8 years' time.
And Steve, so question, and talk a little bit about impact on productivity, absenteeism, presenteeism.
You know, it's a win across the board. If anybody can afford to invest in prevention and wellness, it's employers, particularly large employers, that are paying the bills. Okay, they will gain in terms of loyalty of the workforce. I mean, my annual shareholders meeting turned into employee testimonials. I mean, I could tell you hundreds of lives were saved at Safeway because everybody that worked for Safeway, at least 85% of those that got measured, they all volunteered to be measured. They knew what their blood pressure was, so we didn't have the statistics that you talked about. And so they will be more productive, they'll be more present, they'll be more loyal, and there's an absolute return on investment. And I'm one of those believers that you can cut America's healthcare bill by 50%. And if we could do that, you could pay off the national debt if we all, I would give over those savings to the national debt reduction. In 16 years, $18.3 trillion in debt is gone. And this works in Medicaid and it works in Medicare. I'm about to do this with about 250,000 lives in Medicaid to prove that the principle works for that socioeconomic group as well.
Good. Thank you, Steve. Let's go to Lynn Goldman over here, up in front, and we'll circle around. Lynn.
I thought it was really interesting that both of you had that curve, because that was in my mind as well when you were up there talking about that issue, because it is so important to try to bend that curve and to keep people well and able through their entire lifespan. That is so important. And I think that maybe we could learn some things from other countries. I've been in China, and one thing you see in China that I've never seen here, you go to parks and you see children playing in the parks here. You go to China, you see the elderly in the parks. They're walking, they're doing Tai Chi. It's a social thing. They're playing games, they're playing music, and you know, the data show here that as people become older, they become more and more isolated. Their social connections are being pruned away. They remain where they lived, and which is not in walking distance to a park, mostly, or anywhere else, for that matter. They have to drive, and many of them can't drive anymore. And I think we should be thoughtful about, you know, in a way, planning, you know, for that time of life, and how can we plan to be in a place not where we're, you know, shut away somewhere, but where we can actually have that kind of social connectivity, and that I think is probably very, very important in forestalling disability.
Yeah, one great challenge. If there are any developers in the room, I would challenge you. AARP's stats say in excess of 80% of the people in their cohort, 50 plus, want to age in place and at home. They principally want to age in cities, and so in the city in which we live, which is a city I love, we still have remarkably anemic infrastructure that enables that kind of successful aging. So yes, you can move to a place in the desert with a 9-hole golf course, a shuffleboard court, and a cafeteria and wait to die. But for most people, they want to stay engaged and active and involved, and we don't have it yet. So there's a market opportunity for anybody involved in either the apartment or condo development business.
Can I just add a very quick comment, because this curve also shows that aging doesn't start at 65, like Otto von Bismarck decided many years ago. It starts at birth and even before. And there's things that you have to not to do in the early phases if you don't want to lose the reserve, like, you know, repetitive small traumatic brain injuries. Just think of all those sports. I'm from the country of hockey. Well, it's not good, and it's real bad. Football as well, even the soccer with the repetitive. So these things have to be known and have to be skipped.
There was a question in the second row here, and I'll move this way.
Hi, Hesse. Yay, USC. I'm a scientist by training, and I founded and funded an aging company very recently that's focused on aging in women. We launched this massive digital health initiative in trying to understand the menopausal hot flash in women, sort of key milestone in a woman's aging lifespan. And our preliminary data was complicated and noisy, and we found out that women on a system level is aging and living longer than men. But on an individual level, they were aging differently. How do we address that as scientists and as entrepreneurs? How do we solve the issue of aging if everyone's aging differently?
Well, I think that's a great question. And what are the determinants of the variation and differences in how people age is actually not that mysterious. And we've now developed such an understanding of genomics, and really the fundamental question of what is, from a biological perspective, aging. There's two elements. One is trying to avoid diseases that kill you, and that's very easy to identify now and do something about that. And two, there appears to be a fundamental process of aging which can be delayed by influencing specific processes in the body. And that fundamental aging occurs faster or slower in individuals, and we can identify that and respond to that. There's now a study that's about to start, which will be the first study of this kind to delay aging using a drug called metformin, which Frida doesn't like because you can't make money on it, but it's been off-label.
I would like it a lot if it
Yeah.
aging. Don't you worry about that.
Yeah, it's been off patent for about 20 years. But if you give it to animals, they actually live longer, although not all of them. So by using genomics, epigenomics, and modern technology, we really can address the differences and customize approaches, whether it's women or men.
But at the same time, if I can, we have to study these differences.
Yes.
And they're not. And if you bring just slide 35, this is the current status of dementia in Canada, which is the same all over. 70% of those with Alzheimer's are women. Okay.
35.
Now
Yeah.
what about the research?
And the women that actually have decreased intensity in hot flashes
Yep.
do better cognitively after their hot flashes.
Absolutely, absolutely. So there's something there. Now we've been introducing, I just said, the Canadian Consortium on Neurodegeneration and Aging. We've brought together 350 researchers, our A team. We also have partners, and we had like the Women's Brain Health Initiative. They put money on the table with one condition, that all the consortium, including cells, animals, would look at gender and sex differences. So this is now the first, because all research is done with male rats.
Yes.
They're easier, supposedly.
Hard to believe.
They're easier. So now,
Would you guys just make sure that part is edited out of the tape?
This initiative is going to look at gender difference from cell to public health, because that's what we need. We need to understand that difference.
So
I'm proud to say that the NIH will not fund you today if you don't use
Yep.
both genders in
Yeah.
your studies, and that's
come back to you.
been like that for over a decade.
I think
You're
this gentleman up in the front row, and then we're going to go here, there, and then back to Gret.
Thank you. Obviously, the importance of what you mentioned of the $1 trillion going to be spent by 2050 on Alzheimer's alone, let alone the other issues. And I just want your thoughts on some of the things we can do as non-scientists, non-medical people, such as how important is it for us to get to our Congress people and talk to them about NIH budget and things of that nature.
Frida, you want to start with the NIH budget? I've got some specific
Can
ideas
I do
for
four
business.
things? So
Yeah.
first of all is actually locally, if there are opportunities for you to address some of the issues that we talked about with, you know, kind of your local community leadership, or if you're a part of your local community leadership, to address some of the issues. Some of them are not just economic, they're otherwise, so that would be one. Two is, I think that there are opportunities, not just for the NIH budget, but collectively, for us to use the meta collaborations, these public-private, meta collaborations, to really begin to ask and answer some of the questions. We know Alzheimer's isn't one thing, it's 12 things. We just don't know what 12 things they are yet. Obesity isn't one thing, it's 25 things. We just don't know what 25 yet. So we've got some work to do in this area to clarify, and making sure that there's a stream of funding and focus is, I think, a really good opportunity. And then, Paul, you said something that was really important, and I think it is helping us to understand the economics of all of this, and to help evolve the, I don't want to call it the business model, but the way that we approach health and wellness today is probably not a sustainable system, but we don't know what the alternative system is. And I think the experts in the room in that may have an opportunity to help us predict what it could possibly look like. And then last but not least is, I guess I'm talking to myself, is, would be to take care of yourself, because we do need all hands on deck.
And so I'll mention three things as a non-scientist, non-doctor. One, if you're an employer, understand the benefits of older workers, and retain your older workers. By the way, I'd be happy to share statistics showing about have mixed age teams outperform same age teams. That's one. Two, follow Steve Bird's advice, keep your employees healthy. Three, invest in the longevity economy. We need capital flowing to creative new ideas, innovations, inventions that are going to not only enable better science, but people to have better control of their own lives and their own information. So,
Frida, you were talking about the economics of health and food ghettos, and it seems to me that if we could incorporate the downstream negative externalities of Coca-Cola, it would be way more expensive than water, and the downstream externalities of a McDonald's Big Mac would be way more expensive if you really were having honest accounting than a kale salad. Are there any efforts that anyone knows to actually apply those kind of economics to food?
Mike Bloomberg's not in the room, so we're not going to talk about big gulps. Unfortunately, it's a great question, and it's a really big question. So maybe it's a question that we should take offline and talk a little bit about. Obviously, from a policy perspective, thinking about tax policy and incentives and disincentives, et cetera, associated with food choices is an extraordinarily big issue, but one for a different session. So I want to thank Eve and Frida and Hasi. We can keep going, and probably we should. A lot of you are experts in this room and interested in this topic, and I would encourage you to spend some time with our speakers, and please join me in thanking them. Thanks very much.